So I designed some notes to go along with this class. You can download them for free on Patreon. It would reinforce everything that we are learning here today. And it comes with a couple of questions. So be sure to check it out. Adenosine is very interesting because remember that in the heart, you have two different types of tissues that we have to be aware of. Remember, there's the pacemaker cells, pacemaker, and the non-pacemaker. So remember that these two different types of cells will depolarize in a different manner. So one of them has continuous depolarization, repolarization cycles without any kind of resting membrane potential. Those are the pacemakers. Remember, you don't want to have your heart taking a rest when it comes to conductivity. The non-pacemaker cells do have a resting membrane potential that they have to overcome. Remember that. Basically, what you'll have with non-pacemaker is these type of phases. Well, let's start off with the resting membrane potential. Well, after a cycle of repolarization, the cell will find itself at a resting membrane potential. The two important channels that you should be aware of at this resting membrane potential phase is the potassium leaky channels and the sodium-potassium ATPase. At this stage, the cell tries to maintain its high electronegativity. You do have an increase in the permeability of potassium, so potentially electronegativity will approximate -70. Once that happens, now you have a rapid depolarization phase where the voltage-gated sodium channels open. Sodium rushes inside the cell, bringing the electronegativity from -90 millivolts all the way to +30. So this is called a depolarization. Now that the cell became positive, the influx of certain ions changed their incentive. So let's understand. At +30, you're supposed to close your sodium channels. We're looking at here the early repolarization phase, where a small amount of potassium actually leaves the cell, causing that small dip that you can see here. But then, of course, we have the plateau phase, where you have calcium influx from the L-type channels, and you also start to push out potassium. So this plateau phase is really important because that influx of calcium is going to determine the inotropism of the heart. Now, you do have sodium-calcium exchangers as well, making sure that calcium isn't stuck inside the cell as well. But of course, the potassium efflux will overcome this plateau, leading to a very strong repolarization. So the delayed recidifier of potassium now has help from the rapid delayed recidifier. Both of them are now working to kick the potassium out of the cell as soon as possible, allowing the membrane potential to go back to -90 millivolts, back to resting membrane potential. And it continues over and over again. Now let's also recall the pacemaker cell depolarization, which is different. Now, why am I mentioning this? Because different drugs work in these different phases. So for pacemaker cells, remember, you have a slope that goes like this. And once it gets depolarized, it sharply decreases and goes back into the idea of repolarization. So let's look at this and how it actually works. So here, the depolarization ion, well, let's be specific, the cation, remember, it has a plus, is a cation. Calcium is the major depolarization cation here. This is the one that's driving the depolarization. So how does this happen in the first place? All right, well, you have the cell. It has these sodium channels. So let's say you have sodium. Let's say it's at like -60. Let's say it goes down to -60. You have these sodium channels. They call them the funny channels. But these sodium channels, they can approximate the depolarization level from -60. They approximate it to -50, where you then open up some T-type, transient type of calcium channels, right? And then as it gets to -40, this is where you hit your threshold. And this is the L-type calcium channels. And when this depolarizes, it reaches a peak, right? The peak ends up being positive. And at this stage, calcium channels are going to basically close, and then you'll have the efflux of potassium. Potassium, again, is doing the efflux in order to repolarize the cell. And it continuously keeps happening over and over again, right? This is the whole idea of this. So why am I mentioning this? Okay, I'll tell you. The mechanism of action, like how did this whole discussion start? The mechanism of action started with when we talked about adenosine. So where does this adenosine play its hand? Since this sodium here is allowing the initial push towards a positive electronegativity from -60, it's pushing all the way to -40. This is done by the funny channels, sodium funny channels. But what I'm going to tell you now is that what adenosine targets is a specific protein called A1. Now, don't confuse this with alpha. This is not an alpha channel. It's just called A1. It's a subunit, a protein subunit of the G protein complex. Remember, G proteins, you have GI, GS, GQ. This one formulates part of the process of the GI one, the inhibitory type. So it stimulates this A1 type of receptor that is linked to the GI. And what does this end up doing? It ends up decreasing the activity of adenine cyclase, therefore decreasing cyclic AMP. Okay? And when this happens, you have a stronger efflux of potassium. So notice how potassium here is effluxing. You're having this efflux that brings a repolarization current. But if you activate a stronger efflux occurrence with this channel, then it'll have a deeper repolarization current, making it a lot harder for the sodium channel to bring it to 40, because now the sodium channel is starting this fight from a hyperpolarized state. It's going back to like -70, let's say. It's very hard now to get to -40. It takes longer. It'll take longer to reach this target. Hello, everyone. I hope you're enjoying the video. Please make sure to subscribe and give this video a like. It really helps in the algorithm. Feel free to request any topic on the comment section below. Thank you. So this one here, this adenosine is basically working in the sense that it's stimulating a subunit protein of the G complex GI system, to be specific. And this one basically does inhibition of the adenine cyclase, leading to a decrease in cyclic AMP. Okay. We understand that. Now, what happens here, the usage of adenosine, you're going to see that adenosine, many times it's used to unmask a P wave. Whenever you suspect the patient to have anything of an AVRT or an AVNRT, patients come in with arrhythmia. Let's say patient comes in with an arrhythmia. He has an increase in his heart rate. So we end up doing an EKG, and we see that he has a narrow QRS. It's very narrow, like a little needle, it looks like this. Narrow would mean that it's less than 3 boxes. So it's narrow. Okay, if that's the case, then if he's hemodynamically unstable, we do synchronized cardioversion. Get that out the way. If a patient is coming to you with palpitations with a narrow QRX complex, next step in management for a hemodynamically unstable patient is cardioversion, synchronized cardioversion. Okay, let's say he is stable. Well, we can check for a rhythm. We check for a rhythm. Are the RRs consistent? Are the RRs consistent on the EKG? If that's the case, then we should suspect that the patient might have an AVRT or AVNRT, and we could unmask a P wave by either doing a vagal maneuver or by giving adenosine. Now, in this list, why does adenosine also say vasocutaneous flushing? Well, because it also works on other types of channels as well. Not only A1, you're going to see something called A2. Now, this is not alpha. Just letting you know, just reminding you guys. This A2 channel is found in the periphery system. So the idea of adenosine, the point of that is to basically allow a dilation in the coronary vessels in order for the patient to have more perfusion. Okay? There's a system that we have. I'm going to put this mnemonic here. It's like chalk. So here he goes. These are metabolites that are responsible for promoting the dilation of the vessels, local dilation of vessels. For example, let's say you have a tissue that's ischemic. It needs to be fed oxygen. But how does it tell the body to dilate the vessels in order to receive perfusion of oxygenated blood? Well, it does have a technique, and this is the technique right here. For example, CO2 accumulation on any type of cells will give the incentive of the vessels to dilate. It's telling the vessels, hey, you guys need to pick up this CO2 with your hemoglobin and drop off some oxygen. Let's unload here. That's what it's saying. Hydrogen as well calls up for that incentive. Now, A was for adenosine, what we're talking about right now. It has the mechanism of action as an A2 subunit protein that's coupled to the G complex. It has the mechanism of action of increasing cyclic AMP at this level, at the periphery level, in the vessels. So cardiac tissue, we saw how it actually stimulated the GI system, leading to a decrease in cyclic AMP. But here at the vessels, it's doing a different job, right? It's going to increase your psychic AMP. And if it does this, it does dilation. So this promotes coronary vessel dilation in order to receive a higher level of perfusion. So, okay, that's how adenosine does this. And then, of course, you have lactic acid. When you have buildup of lactic acid, you're telling the body, hey, I'm doing anaerobic metabolism here of glucose. I need oxygen. So the body would understand this, would perceive this as, okay, I must dilate. Then you'll have a higher level of perfusion in order to supply that specific tissue with oxygen, okay? So learn this little mnemonic here just to know that these are the incentives of what's calling over the blood for perfusion, okay? All right. So now that we understand how adenosine makes it difficult for our pacemaker cells to depolarize, there's another drug that also does the same thing from a completely different mechanism. There's a newer drug called ivabradine. Ivabradine has the ability to inhibit the sodium funny channels, therefore making it a lot harder for that cell to depolarize. So ivabradine is used in chronic heart failure with reduced ejection fraction. Remember, you want to have an ejection fraction above 55. If it's below 40, then we call this a reduced ejection fraction. Okay, it could be minimally reduced in between 40 and 50. But yeah, these are like the newer drugs. This is used for that purpose.